Finally, we have Dani Hall. Dani's a paediatric emergency consultant in Ireland and is coming to talk to us about breaking down barriers for LGBTQ young people in the emergency department.
It's winter 2021. We're at the height of the pandemic. I'm in Ireland. We're in our seventh national lockdown. In ED, we have been working through tons of PPE, apron, gloves, masks. Our staff are exhausted. Our patients are really scared. The headlines are really terrifying. One of our ED nurses is volunteering in the vaccination centre. The next patient she sees has just got the letter S on their registration form. And so she says, "What's your name?" And this patient says, "Sarah, but I used to be Sean." The nurse gives Sarah her vaccine, and then Sarah starts crying and says, "I've come here 3 times for this vaccine, but this is the first time I actually managed to come through and get it. And it's because I saw your rainbow badge and I knew that you'd be safe." The nurse sent me a text message with Sarah's story, and it sent a chill down my spine. And it meant that all the work that we've been doing for LGBTQ inclusivity in this awful time was worth it. Now, I'm going to rewind 2 years to spring 2019. It was sunny. We hadn't heard of COVID. I'd recently moved to Dublin from London, but I was back in the UK for the Royal College of Paediatrics and Child Health annual conference. One of the plenary speakers was Dr. Mike Farquhar. Now, Mike was an old colleague of mine. He's a London-based paediatrician. Mike told his story of growing up gay in Margaret Thatcher's Conservative Britain in the 1980s and 1990s. He talked about the stigmatization and the effect that that had on him. He told the story of when he came out to his GP and when his GP said, "I'll keep your secret." He talked about not feeling like he could come out to his colleagues at work and staying closeted until his late 30s in a paediatric hospital. Mike told his story, and then he told us about the Stonewall School Report. He told us that in the UK, 1 in 2 LGBTQ young people in secondary school were bullied, and that number rose to 2 in 3 for the trans young people. He told us about the impact that stigmatization and marginalization had on a sense of worth and on mental health, on the increased levels of anxiety, depression, self-harm, and suicidality. And he told us that 2 in 3 LGBTQ young people in Britain felt that they did not have an adult that they could talk to about this. He talked about the negative attitudes prevailing in the NHS at the time and how that meant that many LGBTQ people did not come for their health because of the fear that they had about the way that they would be treated. Mike told us these statistics, and then he told us about an initiative he'd brought into the children's hospital in which he worked. An initiative called the NHS Rainbow Badge, just a very small little pin that had 2 roles. Firstly, to teach NHS staff about the issues that LGBTQ people face in health, and secondly, to act as a visual symbol to an LGBTQ patient that the person wearing it was someone who would be safe. These statistics really moved me, and when I went back to Ireland, I did some reading, and I found that shockingly, they weren't unique to Ireland. They were the same world. Now, these are the Australian statistics, and they're very recent. LGBTQ young people in Australia, half of them self-harm. 2 in 3 contemplate suicide. 1 in 4 attempt suicide. These are adolescents. These data are 5 to 6 times higher than their non-LGBTQ peers, and they're higher yet again for trans young people. Now, in Australia, there are estimates that 15% of young people identify as non-heterosexual and non-cisgendered. In New Zealand, the statistics are 16%. So these young people, we're seeing them in the emergency department, we're seeing them in our clinics, we're seeing them on our wards. And yet, sadly, psychosocial determinants of health are much worse in this cohort of patients. In Australia, 1 in 10 LGBTQ adolescents experience homelessness at some point. Only half of these young people feel supported by their families, and this statistic is worse in the non-Caucasian families. Drug and alcohol use is much higher in LGBTQ young people, and in Australia, 1 in 4 have admitted to taking illicit drugs in the last 6 months. Eating disorders are also much higher in LGBTQ young people, and particularly so in our trans youth. They're 4 times more common than in cisgendered children. School is not always a safe place. In Australia, 2 in 3 LGBTQ secondary school students say they don't always feel safe at school. Now, this isn't trans young people. This is our homosexual and our bisexual young people too. So you can imagine what this minority distress, the effect that has on a sense of someone's self-worth and their mental health. And it made me think that the role of our healthcare professionals is so vital in creating a safe space for young people to be able to come and access our services. But sadly, that's not the case. In Australia, half of LGBTQ people feel that healthcare providers lack the knowledge and sensitivity to their issues. In New Zealand, 1/3 of LGBTQ young people say they can't access health when they need it. This creates a gap between LGBTQ young people on one side and healthcare providers on the other. And this is a gap that's really difficult for us to traverse. Now, as I was doing this reading, it made me really sad. Like, it made me feel really, really vitalized to be able to do something about the way that we can try and close this gap. It made me think about my own internal assumptions, and it made me challenge the way that I interact with young people. It made me reflect on encounters I'd had with adolescents. Asking the pregnant young person whether they had a boyfriend, assuming by virtue of being pregnant that A, this young person was cisgendered, and B, that they were heterosexual, because I didn't understand the data. I didn't appreciate the effect that this feeling of marginalization and social distress, what it had on a young person's mental health. It made me really think about the way that I interacted with young people, and it made me change the way that I practice my medicine. I started using my own pronouns and asking young people what pronouns they would like me to use for them, and I use this for all young people, not just those that I thought might be trans. Because by normalizing it, it meant that the trans or the non-cisgendered young person was able to naturally respond to me rather than feeling that they either had to hide it or volunteer it to me. And I found that with practice, I quite like doing it at the beginning of a consultation with all young people. So I would say, hi, I'm Dani, I'm your doctor today. I can see on your healthcare record that your name is Sam. Is that the name that you'd like to call me? Because some young people have a different name that they'd like used. And then I'd say, my pronouns are she, her. What pronouns would you like me to use today? And I've been told by the non-cisgendered young people that this really helps minimize the gender dysphoria in using their old names and their old pronouns. It's made me adapt the way that I do my psychosocial assessments, because now when I think about a HEDS assessment, when I ask about the home environment, I don't just ask who's at home and do you get on with your siblings and with your parents, but I ask, do you feel safe at home? Is there someone that you can talk to when you need to talk to them? And is this a place where you feel supported? When I explore education, I'm interested in what they're doing in school, but I'm also interested in whether they feel that they're supported in that school environment, whether there are anti-LGBTQ bullying policies, and whether it's on the curricula. When I ask about activities, I know that being LGBTQ in sports can be very, very challenging. It's not always an inclusive place. I explore what young people are doing on their phones. I mean, young people are on their phones, I'm on my phone. It's a good place to be a lot of the time. But there are also some bad places to be, and I want to understand what they're accessing and who they're accessing it with. I push aside my heteronormative norms when I explore about sexuality and sex. So rather than asking about boyfriends and girlfriends, I ask about relationships and partners. When they're in sexual relationships, I ask about how they met this person, whether they feel safe in the same way that I would normally, but also, do they know where they can go for sex advice as LGBTQ? I explore the stigmatisation of social environments, but I also explore areas of strength. I explore resilience factors. Who is at home? Who is there for them? And do they feel that they've got that person that they can go to? Now, back to my story. It was almost a year past hearing Mike Farquhar in his plenary session, and then COVID hit. This was our first national lockdown. Amidst all the PPE and the policies on social distancing and hot zones and cold zones and cancelled outpatient clinics and elective lists, and whether we were wearing surgical masks or any mask or an FFP2 or an FFP3, we found that our young people were attending in droves to the emergency department with mental health. Lockdown was having an absolutely devastating effect on these young people. And it made me think that me changing my behaviour was not going to be enough, and there was more that we needed to do. So, we looked in the literature and we found something called the LGBT docs. Now, this is a validated survey that's used for healthcare professionals to find out how clinically prepared they feel in looking after an LGBTQ person. And it has 3 domains. We use this across the 4 emergency sites looking after children in Dublin. And we found that our staff had really positive attitudes towards LGBTQ people, which was great. There was very low levels of homophobia and transphobia, as you'd expect. Now, their knowledge kind of fell into the moderate zone, which wasn't too bad, it wasn't brilliant. But when we asked about how clinically prepared do you feel, and remember this is a validated survey that has many, many questions with different weighting to them, we found that their scores were coming out solidly in the low zone. And when you took out the questions specifically looking at the non-cisgendered young people, those scores were even lower. Now, we knew we had to do something about this. We were in lockdown. We wanted to get some education in place, and so we went to the online fora. And we used some existing education. We didn't create our own. We used an e-learning module hosted by our health service in Ireland. It's 40 minutes long. It encourages some self-reflective practice. It's very basic. It's not young person specific. We used a Don't Forget the Bubbles blog post, which takes 4 minutes on average to read. And we found a YouTube video that's 7 minutes long. Now, in total, this education is less than 1 hour. And then we went back and we did the survey again, and like many educational initiatives, we were very pleased to see after 2 weeks that all the scores had risen, and that's generally the case whenever you do any kind of education. And this was across all the domains, and we were delighted to see that this was particularly so in the area of clinical preparedness. But what we were brilliantly, really excited about was 3 months later, and remember we were now probably into our second lockdown, the scores were rising still. We had been in a really shit show time. Not only did we have lockdown and COVID and the rest of it, we also had a national cyber attack, which took down our entire electronic healthcare service, and our scores were still rising, and particularly rising in that feeling of clinical preparedness. Now, we were delighted, but we were slightly confused because we weren't expecting this. And so when we tried to find out why this was happening, we found that that tiny bit of education, I think it was 51 minutes in total, did exactly the same to our staff as Mike Farquhar's plenary had done for me. It made them challenge their own internal assumptions. It made them reflect on encounters that they'd had with other young people. And it made them change the way that they practice with young people in health. And they found that when they had once asked a young person what their pronouns were, or once considered the effect that the social stigmatization had on them, they found it easier to do it a second time, and then a second time made it easier to do it a third time. And they were also educating themselves elsewhere. They'd been going off on YouTube and blog posts and finding more resources and learning more about LGBTQ inclusion. So we took it further. We brought in our own health service badge. We collaborated with a local CAMS unit, and we brought in the HSE Rainbow badge. And we very much modelled it on the NHS badge. It's an opt-in model, so we don't just give them out to staff. You have to sign up actively for the badge. And when you sign up, you have to promise that you're going to do a piece of education, and then you have to sign a pledge that says that I understand that wearing a badge is a responsibility. We put out a massive social media campaign, and we used formerly known as Twitter, to spread the message out across Ireland. And we sent a badge to the head of the health service executive. Now, Ireland is small, but it's not tiny, and we were delighted to see that he actually wore his badge on all of his COVID communications on a daily basis. His successor also wore a badge. Now, I don't know whether it was kind of inherited with the job or whether he applied for his own. Frankly, I don't care, because I think the message it puts out there is just brilliant. And then we asked our staff how it felt for them to wear the badge and what kind of encounters they had had with other staff members and LGBTQ young people and families. Now, I wasn't expecting it to be 100% positive, because I'd spoken to Mike Farquhar, and certainly there had been some negative conversations in his workplace, but we were thrilled with the responses that we were getting. Our staff talked about a feeling of pride. A pride in taking part in the initiative, and a pride in the message and being part of that message that it was sending out to our LGBTQ young people. But really lovely, it was gorgeous to hear that our LGBTQ staff felt proud to represent their community in healthcare. Our staff also talked about inclusion and safety, and I'm going to give a tiny quote. One member of staff said that the badge was a quiet and formidable way of making a statement silently. Our LGBTQ staff also talked about the impact that had on them when they saw another staff member wearing the badge. And our staff talked about the positive effect that seeing the badge and wearing the badge had on workplace culture. And I'm going to read this quote as well, because I would not do it justice if I tried to memorize it. One respondent said, "If I had told myself when I was younger that I'd be working in a workplace which supported LGBT people, I wouldn't have believed it. It was such a struggle being different when I was a child. I feel so fortunate to be able to be completely me at work, and even in a small way support youngsters who aren't so happy in their difference yet. So thank you for making the effort." Now, this is what I want you to do. This is your call to action. You don't have to launch a national health service badge, but you can challenge your own assumptions and think about your own frameworks of reference and push aside your own heteronormative frameworks. You can start to use pronouns, either your own pronouns if you feel comfortable doing it, but definitely exploring young person's preferred pronouns. You can change the way that you do a psychosocial assessment and use much more inclusive language in your questioning. You can go on to educate yourself further. You can go and learn about your own local LGBTQ health needs. And you can use the LGBT docs, that validated survey tool, in your own departments and find out how your staff feel about providing care for LGBTQ people. And of course, you can launch a badge if you want to, because they're quite cool. And if you would like to, the QR code on that side has a link of resources, including a launch pack for the badge, which we adopted off the NHS one. It has a whole set of information, including things like a funding strategy and an example of how you can apply for funding, a communications strategy. It has links to some of the education tools that we used and all the Australian references that I've quoted. Of course, I would be told off by Tessa if I didn't also give you the link to the PEM MSc that we run, because this is something that we cover in our adolescent module, and we use data and information out there to show us how we can change the way that we deliver care in our practice. Now, I'm not kidding myself. I know we haven't bridged that gap for our LGBTQ young people in health, and I know that's going to take a lot of time, and I'm not going to be able to do it single-handedly or with my CAMS unit. But I do know that we're beginning to close that gap, and I think that what we are doing is a pretty good start. So thank you.
Thank you, Dani. We'll go to any questions from the audience.
Well, I don't know who's first.
Just up there, Becky.
This is actually a question. It's a comment. So there's an Australian company called Badgie that makes beautiful stickers for your name badge. They have every single badge under the sun, every single flag under the sun. They've got an ally flag, Aboriginal Torres Strait Islander flag, every other kind of flag. And they also sell pronoun stickers. And we've started putting them, or at least me and a few of my friends have started putting them on our name badges at work, and if it's just Australian people, it's a really good, and they're not that expensive, so it's a really good resource.
Amazing.
Yeah.
I think we will learn next one.
Yeah.
My question's for Beth, and I've got a statement to follow. I'll go with that first. I'm a burritoer. I'm horrified now, and I'm never going to do it again. So thank you for that. You've changed one person's practice. Have you got any advice for kids that have already had that traumatic experience and bringing them back from that? And do you think it's been higher in the COVID session? I'm particularly thinking about my 6-year-old, and again, I'm feeling horrified about the number of times she was held down for a COVID swab over the last few years, and she's actually become quite fearful of medical encounters as a result, and fortunately she's well and doesn't really need to go to the doctors, but I feel very much like I need to bring her back from that. Have you had much experience there and got any suggestions?
Thank you. And yeah, I think all of us are going to have moments throughout our career where we go, oh, I've done something previously, now there is a better way. And I don't think it's about judging our past practice, but it's at looking at what is the next step with the current information, and that's great. In terms of pre-COVID versus current in relation to the medical trauma, I haven't surveyed it. I'm not certain that I've seen it being significantly increased. Like, some kids get more distressed because you're in PPE, but other kids, they've seen people in masks their whole life and it doesn't faze them. So I think a bit both ways. I think doing the work outside of the hospital and the healthcare space is a great time to be doing it, so that you're prepared before you're in that experience again, because once you add in illness and the unfamiliarity, anybody's coping and resilience mechanisms are less. We have some services in our hospital that are related to clinics that can help kids with that, and I'm not entirely certain what's out in the community for that, but I think going through familiar things, looking at things kind of like the social stories to talk it through, and helping to provide age-appropriate understanding is a good starting point. And then for me, when I'm seeing those kids who are really heightened, I have a much lower threshold to go to things like sedation. Because if you are 3, you don't have the rationalisation there. You know this was terrible before. If your kid is going to be coming back and having it again, I'm not going to win in that. In my circumstance in the ED, and I will think about sedating in that child a little bit earlier than I might in another child, knowing that that doesn't mean they're going to need it every time, and we can work towards little improvements every time. And then just schooling yourself up, having a look at the language, having a look at those resources so that you can feel empowered as a parent as well to be advocating for your child, and taking a breath. Most of the things that we do not have to happen immediately. Let's take a pause. Let's get bluey, let's get whatever else, and just give ourselves some time, because we need to be thinking about it through the child's eyes and perspective as a starting point.
Might take one final question for Dani, and I think it was just at the front here. Thanks, Becky.
Thanks, Dani. I've just started in adolescent medicine, and I just wanted to ask you, with the mobile phone use, what do you actually ask your young people about their mobile phone use? And especially for this group of children, what sort of things are you sort of looking out for that would make you concerned?
So I actually just ask them what they're using it for, and they'll tell me to WhatsApp friends. And that's great, Insta and Snapchat. I don't love Snapchat. I've got adolescent kids, so not a Snapchat fan, but I know that that's the space that they're using. And that's great. I'm really delighted when they're telling me that they're using it for messaging their friends, because it means that they've got friends and they've got a group. And when they're telling me that they're using it for scrolling mostly, I then ask them what they're scrolling. And then sometimes they tell me they're using it to meet people, which I'm always a little bit wary about. So it can be great, because if you are the only person you know in your social sphere who's LGBTQ, that's very isolating. And so if you can meet someone else who can support you, that's great. But then equally, if you're looking for a relationship and you're looking online for that relationship, that can be very unsafe. And so it's just really you're doing adolescent, I'm sure you know, in a very non-judgmental way, just asking and exploring and having a conversation around what they're using. And there's always something. But when you find something that's strengths-based, that's great. Then we explore that as well and make sure that's recognised. So, yeah. Actually, I will have one other comment about social media, because there's just something that, there's a quote that someone gave me. So we're doing loads and loads and loads of work in Ireland around this, and we run a conference every year. And there's this amazing charity called Belong To, which is young person specific for LGBTQ young people. And the CEO of Belong To is amazing. I love hearing her speak. And she told the story of being trolled on Twitter by someone who said, "You're trying to make our kids trans." And my way of dealing with that would be to block. Her way was to reply, "I don't care if your kid is trans or not. I just care that they live." And she told this in a conference, and I was like, that's it, isn't it? Because if we can do anything, even if that one Sarah was the only person that this badge has helped, that's enough, because the numbers are low, but the impact is massive. So, yeah.
Folks, let's put our hands together one more time for Jess, Tani, Beth and Dani.